Hello, my name is Jasmine Salazar, and I will be discussing a study on the prognostic significance of PVC and resting heart rate. First, let's get a run-through of how the heart pumps blood. Deoxygenated blood travels through the superior and inferior vena cavas into the right atrium. It then empties out into the right ventricle, where it is pumped through the pulmonary artery into the lungs. Deoxygenated blood then travels through the pulmonary veins into the left atrium, emptying out into the left ventricle. The oxygenated blood then exits into the body through the aorta. These heart contractions are the result of electrical signals. These signals start at the SA node, traveling down to the AV node, where the electricity then travels into the muscles of the ventricles through the His-Purkinje system. Premature ventricular contraction, also known as PVC, is the premature contraction of one of the ventricles. In contrast to a normally functioning heart, those with PVC have extra electrical signals being sent from an ectopic site within one of the ventricles. These then cause premature contractions, as can be seen on an ECG. There are only a few symptoms, including a fluttering feeling in the chest, skipped heartbeats, and a greater awareness of one's heartbeat. PVC tends to pose problems when in combination with other heart diseases. Otherwise, it tends to have little effect. A doctor can hear an irregular heartbeat through a stethoscope. To diagnose PVC, they will then use an electrocardiogram to visualize the electric signals of the heart. If one is experiencing PVC while they take the test, it will show up. To further confirm, the doctor may provide them with the heart monitor to wear for a few days up to a whole month. An ECG allows doctors to visualize the movement of electrical signals through the heart. Doctors place 10 electrodes on the body that detect electrical signals. 6 precardial electrodes will be placed on the chest and 4 limb electrodes on each limb. There will be a resulting wave on each chart as the electricity passes. A P wave will demonstrate the SA node firing signals and depolarizing the atria. Then the QRS complex will demonstrate the firing of the AV node and the ventricular depolarization. Finally, the T wave will demonstrate the ventricular repolarization immediately before the ventricle relaxes. Previous studies, such as those done by Lone and others in the 60s and 70s, predicted that PVC suppression would prevent sudden death. Although this was accepted by many, there wasn't any evidence-based approaches to prove it. Despite PVCs being a common problem among the population, there aren't that many studies on the topic. There are even fewer studies on the relationship between PVC and elevated heart rate. That is why researchers have decided to take on and study and evaluate the prognostic significance of PVC on routine ECGs, as well as finding out the relationship between both PVC and heart rate. These researchers hypothesize that the presence of both an elevated heart rate and a PVC indicates the activation of the sympathetic nervous system, demonstrating a correlation and therefore being able to predict mortality. Let's take a look at how researchers approach this topic. The population for this study consisted of those who had received an ECG for any given reason at Palo Alto Veteran Affairs Medical Center from April of 87 until December of 99. There were originally 47,000 patients who met the criteria, but those with atrial fibrillation and paced rhythms were removed, leaving 45,402 participants. Of those 45,000, 43,671 did not have PVC and 1,731 did. Researchers used the previously mentioned 12-lead ECG, calculating 10 seconds of electrical signals while at rest. They classified PVC as having premature QRS complex, an ectopic-shaped wave, and a QRS duration of less than 120 milliseconds. Of the 1,700 that were found to have PVCs, 88% had non-complex PVCs and 12% had complex PVCs, saying that they had over 2 consecutive spouts. For those without PVC, their heart rates were automatically calculated. For those with PVC, their heart rates were calculated manually by calculating the distance between 2 R&R waves, except when Bajimini made it impossible, as shown in the red box. There were also follow-ups done after an average of 5.5 years with the patients. Deaths were then taken from the Social Security Death Index, and causes of death were taken from the California Health Department service. All-cause and cardiovascular deaths were taken in as data. Table 1 demonstrates the overall demographics and ECGs of the participants. There is a slight difference regarding the average height, weight, and BMI, but they pose little significance. Those with PVC were found to have a higher average heart rate than those without, coming in at 78.6 compared to a 73.5. When patients were divided into groups based on gender, race, and outpatient-inpatient status, those with PVC always had a higher average heart rate. Table 2 addresses the demographics and ECG findings for patients with single versus multiple PVC and patients with non-complex versus complex PVC. 53% of the patients of PVC had single PVCs and 47% had multiple. There was only a significant difference between the heart rate, as those with single PVCs had an average heart rate of 77 and those with multiple had an average of 81. Regarding those with non-complex and complex PVCs, there were significant differences in age, as those with non-complex were younger at 65 and with complex were older at 68. There was also a greater significance of the prevalence of Q waves, as those with non-complex experienced it at 23% and those with complex at 31%. Lastly, there were significant differences between the average heart rates of those with complex versus non-complex PVCs. Those without it had an average heart rate of 79, and those with it had an average heart rate of 84. 39% of all the deaths, or 1.5% of the total population, experienced cardiovascular death. Cardiovascular mortality was more prevalent in those with PVC at 3.5% than those without it at 1.4%. Annually, 5.1% of those with complex PVCs would die of cardiovascular mortality. Although more patients with complex PVC passed away of all-cause mortality or cardiovascular mortality compared to those without complex PVC, there was no statistical significance. In regards to heart rate, mortality increased as heart rate increased, and it doubled if PVC was present. In those without PVCs, if they had a heart rate less than 60, their cardiovascular mortality percentage was 6.3 compared to the 12% of those with PVC. Cardiovascular mortality was as high as 26.1% in those with PVC, as they had heart rates over 99. This last chart gives a clear overview of how different the cardiovascular mortality percentages are between those with and those without PVC. Those with PVC have an average double the size of those without. After gathering data in this study, one can conclude that PVC, if found on an ECG, can be a predictor of all-cause and cardiovascular mortality, regardless of whether it is singular or complex. Heart rate is also an independent predictor of PVC, as PVC is commonly found in those with elevated heart rates. An active sympathetic nervous system also plays an important role in the formation of PVC, as the body tries to activate and increase heart rate. Lastly, the high number of deaths noted during the follow-up demonstrated how a combination of elevated heart rate and PVC increased the risk of mortality, as those with high heart rates and PVC experience a higher percentage of death. Thank you for listening to my presentation.